Hello, everybody. My name is Carlo Di Lorenzo, and I'm a pediatric gastroenterologist from Nationwide Children's Hospital. I've been asked to talk about IBS and functional abdominal pain in children. This is the mandatory disclosure slide. I will not discuss any unapproved or investigative medication or device. But before I get into the meat of my presentation, I want to just spend 2 words of just to give thanks and 2 words of gratitude to Nancy and Bill Norton. I don't think it can be underestimated how helpful and beneficial they've been to the entire field of gastrointestinal functional disorders. Their advocacy, their commitment to education and research has been second to none, and single-handedly they have advanced our field. And on a personal basis, I still remember very fondly when 20 years ago, I was invited to give one of my first presentations at the 5th IFFGD meeting, and I've been grateful that they have continued to invite me on the next for the next few meetings. And that has helped my career, has helped me to network, and it has helped the field to progress. So from the bottom of my heart, thanks to Nancy and Bill for all they've done for all of us and for the children who have functional GI disorders. So what are these disorders? These disorders are quite common. We've learned quite a lot in the last 30 years. For example, they are extremely prevalent in our practice and in general. Miguel Saps has studied the prevalence of irritable bowel in children of many different countries, both in South America and Central America, and he has found that they are exactly the same as they are in terms of prevalence in the United States. About 10 to 12% of children at any point in time in high school and middle school fulfill diagnostic criteria for irritable bowel or functional abdominal pain. So extremely prevalent. And they are very costly. He has done actually another study in when he was still in Chicago, and it's found just for the testing, not for the impact on the parents or hospitalization and so on, but just for the testing. Children that make it to a pediatric gastroenterologist account for about $6,000 per patient. Once again, just for the investigations. And he found that in his cohort of patients seen in his GI clinic, about $1 million was spent with very little payout, very little positive testing. And now we understand the pathophysiology. In the last 20, 30 years, we've figured out that these very prevalent and costly pediatric GI disorders come and are produced by a faulty interaction between brain and gut, right? Between the central nervous system and the enteric nervous system. There are psychological and cognitive factors that interact with gut, luminal and mucosal factor to generate the symptoms. And what we found out is that the more severe the symptoms are, the more relevant are the central nervous system type of factors. So that also leads to the conclusion that our treatments probably need to target the CNS a lot more than the ENS in the patients with the more severe symptoms. And understanding the pathophysiology has also led to a change in nomenclature. What we used to call functional GI disorders are now called disorders of gut-brain interaction, as pointed out in this special issue of Gastroenterology. This was one of the Rome 4 conclusions, and I'm sure it's going to continue to be a central theme of the Rome 5 new efforts. We've also learned that in pediatric GI, gut-brain interaction disorder, the parents play a very significant role. In fact, the parents can play a very positive role in helping and directing the child how to cope with the symptoms, and they can actually produce beneficial impact on the child, can lessen the symptoms. On the other hand, they can also have a negative impact on the child, can actually, with their catastrophizing, increase anxiety and produce symptoms in children. And in fact, there is this fairly old study that showed that parental anxiety predisposes children to development of functional abdominal pain. You can see here in this bar graph as having no anxiety compared to having two parents with anxiety led to a doubling of the risk of developing functional abdominal pain in children. We now know how to test, right? We have learned the pathophysiology, we learned the risk factors, and we now learn how to test. We look at alarm signs, red flag in the child that can become apparent based on a thorough history and physical examination. Things that like involuntary weight loss, blood in the stools, unexplained fever, and family history of IBD, for example, are well-tested alarm signs. Others are not quite as considered red flag, or maybe a little bit more of a pink flag, like nocturnal pain or pain away from the belly button. We have learned that those things may actually be quite common in patients with organic diseases as well. Then we look for green flags, things that are much more likely to lead and be present in patients with functional GI disorders. A pain that is always there, unassociated with GI events like eating or having a bowel movement. The presence of many other somatic symptoms, dizziness, headaches, fatigue, and so on. The coexistence of anxiety, depression, and as I said, parents that are quite anxious. We've learned that in terms of testing, there are really only two tests that in the absence of alarm signs are cost-effective. And those are serologic testing for celiac disease and stool measurement of a fecal calprotectin. Those are two tests that even in the patients that do not have alarm signs or red flags are probably worth performing. And in fact, we also learned that when a diagnosis of a functional GI disorder is made, it has an impact on outcome, on prognosis. This was a study done in Croatia that looked at different prognostic factors for patients that have children who have irritable bowel or functional abdominal pain. And they learned that making an early diagnosis led to a doubling the benefit, a doubling of a positive outcome in children with those conditions. And we also learned that the opposite is true. Delaying a diagnosis is associated with a tremendous amount of morbidity and poor prognosis. This is not cost effective. There is no limit on how many tests we can do. Sometimes we see patients who receive the same test over and over, hoping that maybe it will give a different outcome. Increases anxiety and uncertainty. It's hard to provide effective reassurance if you keep ordering tests. And you postpone treatments, right? People were not going to buy in a treatment for irritable bowel if they're still worried about a gallbladder disease or a food allergy. And then the most problematic issue of all, the danger of unrelated and often irrelevant findings done in those that are the outcome of those tests. And this is critical. And in fact, there is a beautiful editorial came out a couple of years ago by Sam Nurko and Neil Schechter. They show that well-meaning physicians cause actually morbidity by giving other diagnoses as a result of false diagnostic criteria or tests that come up with unrelated findings. The danger of diagnosing rare yet well-defined entities such as Ehlers-Danlos syndrome, mast cell activation syndrome, sometimes based just on symptoms that are very difficult then to undo, and they decrease the buy-in of the patients in a diagnosis, for example, of functional abdominal pain or irritable bowel. So be careful when you test. Diagnoses have side effects. We now know how to treat as well. So we know that these conditions are costly, common. We know that have a tremendous impact on the child's quality of life. We know how to test. We know how to treat. We have made a lot of progress in the last 20 years. We have learned that we need to acknowledge and address the mental health component. We are in the middle of a true anxiety epidemic in children. There's been, look at this graph. In the last 10 years, the number of patients going to an emergency department for any reason has been pretty flat. But the number of patients that have gone in for suicidal ideation or suicidal attempt has doubled. And now in the middle of this COVID epidemic, this pandemic, the American Academy of Pediatrics just published a white paper showing once again the number of children who went to the emergency room in the middle of a pandemic for somatic symptoms, for any other reasons, decreased. But the number of patients who went for mental health disorders skyrocketed. We see a lot more of these patients. Intentional self-harm, overdose, substance abuse, they are skyrocketing in children. And they have an impact on the functional GI disorders. So we're going to see this more and more, and we better learn how to address this problem, right? In the diagnosis, we need to provide, in the treatment, we need to provide positive diagnosis, explain and reassure, but also give lifestyle advice. The importance of sleep, physical exercise, going back to school, how to integrate back the child in normal, age-appropriate activities. Suggest the use of meditation and yoga, which may provide tremendous benefit on children, for children with functional GI disorders. What about diet and psychological treatment? Obviously, I just mentioned to you the tremendous prevalence of anxiety and depression. We need to discuss those conditions, and we need to use things like diet and psychological interventions, which is often very well accepted by the families. A low FODMAP diet has been shown to be effective in adults and children with irritable bowel. There is decreased amount of bloating, decreased amount of pain in patients who receive a low FODMAP diet. Remember, this is not a no FODMAP diet, it's a low FODMAP diet. Do it strictly at the beginning, involve the dietitians, and then reintroduce the symptoms stepwise, one at a time, to find out what is the threshold to develop symptoms. The most effective treatment is hypnosis, cognitive behavioral treatments. In this beautiful study done by Mark Benninger in the Netherlands a few years ago, they showed that they were, compared to standard medical treatment, there was a tremendous benefit for cognitive behavioral treatment. In this case, was gut-related. In this case, was gut-related hypnosis. And now we have a psychogastroenterologist, people that have developed special expertise to treat functional GI disorders in children and adults. And you can find them all over the web. Very easy to find where they are in your local area. Why no drugs? I told at the beginning I wasn't going to talk about drugs. One of the reasons is that in adults, there have been a lot of medications that have been approved in the last 15 years for treatment of IBS and constipation. In children, none. In fact, when those drugs have been tried in children in large multi-center, double-blind, placebo-controlled trials, usually the results have been negative. They were just as good as placebo. One device, on the other hand, was approved by the FDA for use in children, even before then in adults. That's a nerve stimulation wearable device that is actually an auricular stimulator. This was used by Carlo Kovacic and colleagues in Milwaukee to treat children with irritable bowel and functional abdominal pain. And what they found is dramatic decrease in the patients who were complaining of severe pain when wearing this device. Children were wearing it for 5 days, a week for 4 weeks. Compared to sham feedings, you can see here improvement in functional disability in favor of the percutaneous electrical nerve field stimulation. Once again, I want to thank IFFGD for all the work they've done in the last 30 years. They have helped countless children with functional abdominal pain. And from the bottom of my heart, thank you so much.